Good evening, everyone. Welcome to the webinar hosted by Olympus. I am Brian Schneider, Senior Product Marketer for Olympus's Endourology Division. Our event tonight features the esteemed Dr. Ahmed Ghazi of the University of Rochester and his independent clinical abstract measuring the performance of the SOLTIVE SuperPulsed Laser against high-powered Homium YAG technology. This is one of the very first North American clinical abstracts to offer this comparison, so we're thrilled to have Dr. Ghazi here to discuss his work live with us. Before we begin, for legal and regulatory purposes, please be advised on this disclaimer. Dr. Ghazi is the authoring physician of this content and is here tonight as a paid consultant of Olympus. However, it is also important to note that the prospective study he will discuss tonight was performed completely independent without sponsorship from industry. The investigators' conclusions derived from the study are their own. A few housekeeping points for the next hour. For the duration of the call, the audience tonight will have their cameras off and microphones muted. We encourage everyone in the audience to ask questions in the chat box at any time during the presentation, as Dr. Ghazi may have opportunities to address them as we proceed. There's also a built-in questions checkpoint immediately after Dr. Ghazi presents on the results of his abstract. To keep engagement interactive, we wanted to begin tonight with an audience check-in poll to see which topics you are most interested in learning about during this engagement. Please select all that apply. These options represent the most common questions physician asks Olympus on a day-to-day basis. While SOLTIVE has been fully launched now for approximately 2 years with tens of thousands of patients treated with this new technology, there are no shortage of clinical champions across the U.S. and globally. There are economic buyers and clinical evaluators who rely exclusively on real-world outcomes and health economic data to drive technology decisions, and still view SOLTIVE as relatively unproven versus Homium YAG. So as new data emerges from extensive use, this viewpoint may change. And here are the results of this survey, and certainly, certainly my statement there, what I just stated, reflects the outcomes of this survey. Many here are interested in hearing about the clinical outcomes. Different energy settings and different techniques for different stone applications is also something that across the board everyone in the audience would like to see. So we will certainly have Dr. Ghazi address all of these in the coming hour. With that, let's get to the reason why you're all here this evening. Dr. Ghazi received his medical degree from Cairo University in 2000, where he also completed his surgery training and urology residency in 2005. For the last 11 plus years, he has been a board certified urologist in the US. He is very well respected in the urology community and is heavily published with close to 60 different original publications to his name. His clinical and academic focus is dual in nature, specializing in the diagnosis and minimally invasive treatment of cancers of all genitourinary organs, as well as minimally invasive treatment of urinary stones. His 3 separate current appointments are listed on the screen. I present the world-renowned Dr. Ahmed Ghazi of the University of Rochester.
Brian, thank you very much for this very kind introduction. And I want to also thank the audience for joining us in this event, where we are going to talk about the clinical outcomes based on our own experience with the thulium fiber laser. It is very interesting to see how new technologies can change our perspectives, especially in something like stone lithotripsy. And I remember when the Homium laser was introduced, we were comparing it to pneumatic type of energy devices or lithotripsy devices. So I'm very happy to be able to present something to show how our experience has changed using this new type of laser technology. I want to also thank Olympus for really sponsoring this event and bringing it to the landscape. Very interested to see also the results of the poll, where the audience was concerned about clinical outcomes and also concerned about issues related to the different energy settings, both which we will address today. So if we want to start with the armamentarium that we have available for high-powered laser, because that's really what we're going to talk about today, and high-powered laser for lithotripsy. And we have multiple companies and also multiple products in the market right now. We have the Empower, the Olympus Empower. It's a 100-watt laser. All of these are Homium YAG technology. We also have from Lumines 2 different types, which is the Pulse and the Pulse 100 and the 120. And these include the pulse modulations also, which is the Moses technology. There is the Cook laser, and there is also the USA, the Sphinx laser, and the laser from Dornier. I'm sure many of us have either one or even two of these lasers within our own hospitals right now, and it's something that we're very customized to using. The reason why we are looking at really driving this popularity of utilizing a new type of technology and the evolution of these types of lasers is there is an increased popularity of the dusting technique. More urologists are looking towards using dusting as their primary lithotripsy approach rather than using fragmenting and basketing. And the reason for that is because of the limitations of you really needing to put an access sheath. Not only does sometimes it leads to injury, but sometimes you really cannot get an access sheath all the way up to the proximal ureter where you need it to collect stones or basket stones. There's also, hospitals are moving towards this aspect of one type of laser for all. They want a laser that does both the stone approaches, but also is utilized for soft tissue, example, BPH or even bladder tumors. So they want one laser that works in all applications rather than have multiple types of laser technologies that are purpose-built for different type of applications. And we're all aware of the changes in lifestyle and the changes in the diet that has really increased the number of stones that we are seeing in our offices and in the emergency room. But there are also limiters on the other side that are really pushing us away from using Homium laser as our ideal approach or our standard approach. The biggest thing is that the cost of flexible uteroscopy is really going up, as well as the maintenance costs. A lot of people would prefer doing PCNLs for stones that are about 2 centimeters, and some people would even go into 1.5 centimeters based on the density of the stones, just because it is an approach that is more reliable, while at the same time it also offers better stone-free rates. And a recent publication also showed that no matter how good we think we have achieved stone-free rates with uteroscopy, they are far inferior to PCNLs. A lot of people, like I mentioned earlier, have grown unsatisfied with the fragmentation technique because not only do you have to collect these fragments, but we all know that our baskets are not really made to collect even small and large fragments at the same time. So there is always something that is left behind. And if you really are very keen to collect all the small fragments that are inside the kidney after fragmentation, you spend almost 45 minutes extra in the procedure to really clear out that stone. So dusting seems to be a better option, a more cost-effective option, an option that's better for the patient, but also something that would improve our efficiency in the operating room. We're also very, as much as we are used to the settings that are offered in the Homium YAG lasers, we know that there are limitations to how far we can go in the frequency and the joules. So if we look at the limitations of the Homium YAG technology, which is an incredible technology to begin with. Remember, before we were using pneumatic lithotripters, and we were using lithotripters that were way inferior. Laser technology itself and the iterations and the generations of Homium have really improved the way that we treat our patients. But as we know, technology is always advancing, and we're always looking for the next best thing for our patients and for us as urologists also. So there's the limitation of the frequency. We're all aware of that. We also know that the technology of Homium YAG itself leads to less efficient energy delivery at the tip of the fiber. And I'll go into that in more details. The beam itself, because it uses a series of mirrors in order to really colaminate the laser beam, you end up losing a significant amount of energy in the process. Even though there is pulse modulation, but it is shown in vivo studies that the pulse modulation is not only short, but it's also irregular compared to the thulium laser fiber. And also they use the multiple cavities configuration in order to reduce retropulsion. This leads to time-consuming stone ablation. It also leads to larger stone fragments. So even though you're dusting, the stone fragments that end up, or the dust that you end up, is pretty much not micro dust. It is large fragments of dust, and sometimes you can see some stone fragments in there. The fibers that are used with the Homium YAG are limited to a certain diameter, and this is because of the limitation of the technology and how the beam is colaminated, or the laser beam is colaminated at the point of where you would attach the laser fiber. We're always aware that the excessive heat that is produced inside the body, but also from the laser itself, and that's why these lasers are huge, because they require very sophisticated cooling systems. Retropulsion is a big issue, and in the beginning, when I started using this laser, I was kind of skeptical about the fact is, why would something that is delivering more efficient energy leading to less retropulsion? And we'll get into the details of why it really does reduce the retropulsion. But as we are aware, there is a specific laser that was generated or made and modified to offer less retropulsion because of that issue. And of course, when you move a laser from one room to another, like all of us have done before, we've often seen the malalignment of these mirrors and that it is very sensitive to external trauma, and which would lead us to increase our maintenance costs, and sometimes we would have to abort procedures. Moving on to really putting, and I really like this slide because this slide really does a head-to-head comparison. Even in the pictures, you can see the size of the gold standard laser lithotripsy that we have now, and looking at now the SOLTIVE, or the thulium laser fiber by Olympus, and you can see it's not the entire thing, it's actually only the top part of this cart. And that is not only a reduction in the voltage that is required off the thulium laser, and you know that you are only allowed to use a Homium laser in certain rooms in your operating room that have that special outlet. Here, it is something that you just plug into a wall outlet. It is basically the amount of energy that you would need for 1 or 2 hair dryers. That's how much less energy this laser requires. And if you also look at the ideal weight, the weight is far less, but it's also because there are no mirrors that are inside the laser that are acquired in the thulium laser. You actually do not need, it is less prone to malalignment of those lasers and trauma. So when you're moving it from one room to another, it is less prone to being damaged. Now, getting into the real value of these lasers, we look at the pulse energy, and the joules do go at a maximum of 6 joules in both lasers. But if you look at the minimum amount of joules that you can get out of the 120 watt Homium LAG laser, it's 0.2 joules. But SOLTIVE, or the thulium laser fiber, can go all the way down to 0.025. And it is almost as effective at that energy settings to the 0.2. And again, I'll explain to you why. Looking at the frequency, and this is where the difference is almost enormous. The maximum frequency is 880, while the maximum frequency in the SOLTIVE can go all the way to 2400. Now, I wouldn't advise using 2400, but I'll show you one of the videos where I maxed out my frequency, where I felt it was safe, and it really led to significant effects in stone dusting. And it'll be very interesting to show you that video. And finally, pulse duration. Now, also looking at pulse duration, not only is it shorter in the Homium YAG laser, but it's also irregular. Keeping the irregularity aside, the pulse width can go all the way up to 12,000 compared to the 1,300 that you would see in the Homium YAG. So these are, the inherent differences, one-to-one differences between both lasers. But what is the clinical effect of all of this? And that's really what we're going to look at today. But before I get into that, I really wanted to discuss, what is when you look at this technology, I read up quite a lot to look at why is the thulium laser fiber different than the Homium laser fiber, and the beauty of it is all in the wavelength. The wavelength of the Homium LAG is 2120, and the wavelength of the thulium laser fiber is 1940. Now, all of these seem very close to each other, and they are in the far infrared spectrum. The inherent difference is really in the wavelength of the thulium laser fiber is very similar to the water absorption coefficient. That means that when the energy delivered by the laser travels in water, it loses less energy. Taking that to the next level, if you really want to get into the nitty-gritty of this, it's really based on the optical penetration depth. So it is the amount of depth that is required to go through the medium, which is water at this point, to produce the threshold for ablation. And in the thulium laser fiber, it is 4 times less than the Homium laser fiber. So if we look at the slide here right in the middle, looking at the optical penetration depth of the Homium laser in water, there is a reduction of energy of about 37% as it travels through that. And if you look at the thulium laser that reduction is 1.7%. Now, if you extrapolate that into, because of the algorithmic nature of the equation itself, look at 1 millimeter, which is basically the optimal position where you would place your laser in front of the stone for ablation. The energy lost by the Homium laser is 4%, while that of the Thulium laser is 16,000 times less. And this is because of the algorithmic nature. And that's why they say Thulium laser is 4 times more effective, just because it loses less energy in the process. Another thing that is very interesting, and you will see it in one of my videos, because the absorption coefficient, or the absorption coefficient of the Thulium laser fiber is similar to that of water, any water bubbles or water cavities that are present inside the stone, when encountered by the laser, would result in a vaporization bubble. And that vaporization bubble leads to almost automatic microfragmentation or microfracturing in the stone, right? So when you're trying to break through a very hard stone and you have these minute cracks in the stone as a result of the water vaporizing when the laser fiber gets close to it, you result in a weaker stone that you can fragment or even dust better. And that is something that you would see in the laser at certain settings. And the last video actually shows that quite significantly. So what is the Thulium fiber, right? The Thulium fiber is basically a 10 to 30 micron fiber. And the whole premise of the Thulium laser fiber is the fact that the Thulium, it has a core of 10 microns. And that core is your gain medium, because your gain medium is what the lamp activates that medium to produce the laser beam or the Thulium radiation. So that Thulium fiber, or that core, is impregnated with Thulium ions, and it's equally distributed. So now the LED light activates that core, it results in a radiation beam. And that radiation beam is within the fiber itself. It doesn't need to move across mirrors to create a beam. The beam is created in the fiber. And therefore, as a result, when you attach your fiber to the end of the laser, that fiber is in direct contact or in alignment with the Thulium generating fiber or the gain medium itself. So that leads to two things. You are delivering more efficient energy at the fiber, which is being delivered inside the patient's body because of that direct contact and alignment. But the second part is you can use fibers as small as 50 microns. Now, I know the smallest fiber that's available on the market now is 150, but this laser has the capability of producing fibers as small as 50 microns. And that would be a huge revelation in our ability to use them within flexible scopes and even smaller flexible scopes without impeding flexibility or irrigation, which is an important aspect, for example, of lower pole stones. Now, if we look at the Homium laser, that's a little bit different. So the Homium laser, what it has is it has a crystal rod that's several centimeters wide. And that crystal rod is what is activated, is what is impregnated with Homium ions. And the light source, or you need a very high light or a lamp in order to activate that Homium. And that's why you need a very high energy source. And therefore, that's why you need a special type of output to place or to plug the laser into. Once that then activates and develops the Homium radiation, you then have to colaminate the beam. So the beam then has to become colaminated, and that's where the mirrors come in. And as a result, at the end of it, you result in a beam that is then attached to the fiber. So the fiber is not in direct alignment with the gain medium because it has to go back and forth in a couple of mirrors in order to get that beam. So that, from that perspective, that's where the efficiency of the laser and the technology comes in the Thulium laser. Now, in addition to the Thulium laser having that core where the gain medium is and where it is excited, you also have this part where around that core is kind of a clad that has a refractive index that allows the laser protons, if they escape, here in the red on the left, they can be refracted back into the core itself. So you lose very little energy coming through the laser fiber itself. So inside that blue jacket that we see, there is another there's another layer, and that layer has a refractive index that allows the protons to bounce back into the core. So again, you're optimizing the amount of energy you're delivering at the fiber itself. I know this is getting a little bit boring, but believe me, this is how you will really understand how this technology is truly improving the efficiency of your ablation and also giving you a wide breadth of frequencies. And also you're able at lower pulses. So at the 0.025 pulse, you're able to produce an effective energy that is able to ablate a stone, because the energy itself that's emitted from the fiber, very little of it is wasted as compared to Homium Laser. This is under light spectrometry, showing you the difference between the colamination of the fiber that is coming out of the thulium beam and what is coming out of the Homium. And you can already see the difference in how it is uniform in the thulium laser versus in the Homium laser. And that's why you're able to deliver more effective energy at the end of the tip of the fiber itself, which is in contact of the stone. This is the crystal cavity, or that rod that I talked to you about. And this requires a significant amount of cooling, as opposed to basically the fiber, where air can be used to cool it versus water in the thulium laser fiber. And that's why the significant difference in the size of the lasers, right? This red box is the entire cooling system that's required in any Homium laser, as opposed to just basically air vents like your laptop that is in the SOLTIVE or the thulium laser fiber. And the percentage or the ratio between the cooling component and the laser generating component is very different in both lasers. So we also discussed the fact that it requires really very little amount of energy. You can basically plug it into any wall plug versus needing to plug it into a specific wall plug, limiting where you can use it in your operating room. So in conclusion, the value of SOLTIVE or the thulium laser fiber is you can dust a stone in half the time, and these are all in vivo tests that were done. You can also fragment the stones more effectively, because you're also able to vaporize the water and crack the stone from the inside, because the wavelength of the thulium laser fiber is very similar to that of water. Because you're able to deliver more efficient energy, you're able to ablate similar stone volumes with less energy settings, and that is the reason why you have low retropulsion. The idea also for retropulsion is the energy that is delivered at the tip of the fiber is directly delivered from the fiber itself, so it doesn't push the stone away. And when you look at the settings that I use in the thulium laser fiber, the pulse width ranges from 1 to 3, which are the 3 bars that you would see in the SOLTIVE laser. In a Homium laser, you would say one of them is to decrease retropulsion, which is the wide pulse width, versus the other one, which is to decrease the retropulsion, or you would have more fragmentation. The stone would move around, so you do more pop dusting. Just be aware that in the thulium laser fiber settings, all of these are considered to decrease the retropulsion. You're just changing the amount of time the laser or the energy is contacting the stone. So don't think that if you're putting it on bar number 1, that is going to have high retropulsion. That is still a low retropulsion setting, but it's a more efficient way to fragment a stone. You can use smaller laser fibers. Again, we mentioned the 150 and the 200, but there's really a push to get even smaller laser fibers. And you can do very good soft tissue ablation. And although this is a talk about stone lithotripsy, I'll show you a patient that was post-PCNL that had a stenotic lower pole, and very easily we could just change the settings in the laser itself and start kind of doing tissue incision with minimal bleeding. Again, we talked about that this is a one platform for both BPH and for also, although it's only 60 watts, but because the 60 watts for the thulium is more effective, it really is equal to the 120 Homium laser that you have available. You have a great range of settings, and you can literally use it in any OR room. Also, the sound it generates, it is a much quieter laser. And there's a study that was done and showed that the Homium laser actually produces 70 decibels while it's working because of the cooling function and the fans that are required. And the average setting that is required within an operating room to maintain kind of communication is about 50 decibels. And the SOLTIVE laser is about 40. So it's a much quieter environment. And again, we talked about the mirrors and the malalignment that do not require really a lot of maintenance to be done also. So these are all the abstracts that are published. A significant amount of them, like Brian had mentioned in the beginning, are in vivo studies and in vitro studies. And we really did an in vivo study to look at the clinical comparison. And this is the next component I wanted to talk to you about. So this is a clinical study that was done at the University of Rochester, and it was registered in clinicaltrials.gov. It is a prospective study that was done. It is not a randomized study. And the reason for that was the availability of the laser. So we had any stones ranging from 5 millimeters to 30 millimeters that were really scheduled for upper tract retrograde intrarenal surgery, basically uteroscopy, were enrolled in this study. We had 3 urologists, all of them are fellowship trained, that used the Homium Laser, in the Empower 100, which is a high watt laser, and the SOLTIVE Laser. And the way that we did this is we had the laser available at our institution for a window of 6 to 8 months. So what we did is we started off by using the SOLTIVE laser for 6 to 8 months for any patients that fit the inclusion criteria. Of course, these are not patients with solitary kidneys or patients that were obstructed, that required stenting or prior stenting. These are patients that basically had somewhat non-obstructing or partially obstructing stones in the upper tract that were not previously stented, and we did not, for the majority of patients, we did not use access sheets. And then after that 6 to 8 window period, we then did not use the SOLTIVE at all and used our Empower laser, where we enrolled 31 patients also that fit the inclusion criteria. So it's not randomized, but we were not able to choose between patients. If they fit the inclusion criteria, then they did laser lithotripsy with uroscopy, and they had to use the laser that was, in that period, it was designated to use this laser. We had 31 patients enrolled in each group, and in order for us to really be able to do an accurate clinical comparison, and this was a point of the debate very early on, we actually utilized fixed laser settings. And these are laser settings that were previously published for both Homium and Thulium that were known to be dusting settings. And this is 0.4 joules, 60 hertz at 24 watts. Again, not the ideal settings, but we needed to fix the settings in order to actually compare apples to apples. The surgeons were then, all these videos were recorded. The surgeons were blinded to which videos included which, and we had them rate on a Likert scale of 1 to 5, the retropulsion, the visibility, and the bleeding. One of the things, before I forget, you will notice in this laser, a lot of people say it chars the tissue. That is true, but the idea behind that is that it causes very minimal bleeding. All of you would recall that at some point within the Homium laser lifestyle or the procedure that you're doing, you will find out that you had to stop the procedure halfway through because there was just too much bleeding. And this is inadvertently when the patient is, for example, taking a deep breath and they're moving, that you would hurt the mucosa. It does lead to a good amount of bleeding, which affects visibility. Here, the visibility is not only impacted by the less bleeding, but is also impacted by the fact that you do not produce a significant snowstorm effect. All right, you produce fine dust, but it doesn't really alter your ability to visualize the stone. The primary endpoints that we looked at were total operative time, which is basically uroscopy time. We looked at what we call laser on time, and this is the amount of time your foot is on the pedal during the laser activation, right? Because the laser really looks at the number of seconds that you utilized the laser when it was on. But we also looked at lithotripsy time, which is the time that they say laser on and laser off. So the time in the middle is basically pausing for you to adjust your scope, pausing for you to be able to irrigate and get the snowstorm effect out of the way, pausing also to reduce the visibility, to improve the visibility from bleeding, and chasing stones that have moved around because of the retropulsion. And this is where the operating duty cycle came in. The operator duty cycle is known as a term where you take the laser on time, which is the total time the laser was active, on your total lithotripsy time. And this is a measure of efficiency. So for example, if we used 10 minutes of laser time or 10 seconds of laser time within a case in both lasers, but we did this in the Homium laser over 100 seconds versus in the Thulium laser over 30 seconds. That shows that you paused less. Your foot was on the pedal consistently for a longer period of time in one laser opposed to the other. Right? So the more the operator duty cycle that you have, the more likely your laser is efficient because you are utilizing less laser on time within the same lithotripsy time. We looked at ablation efficiency, which is the energy required to fragment 1 millimeter cube of stone. And that's by just dividing the joules over the ellipsoid diameter. So we use the ellipsoid formula to get the stone size. and the ablation speed, which is the same thing. You divide the stone volume by the number of seconds you spent lasering, showing you how much millimeter cube of stone you broke down or ablated in every second when the laser was on. And these are the comparison of both groups. So 31 in both groups. We looked at the differences in age, in body mass index, in the number of stones in each of the kidneys. We looked at the stone densities, and we also looked at the stone volume using the ellipsoid formula, and we also looked at the stone score. The stone score is a published, validated metric to really show you the difficulty of the uteroscopy itself, and it looks at the stone location, the number of stones, the obstruction itself, and also the density of the stone. And there was no difference in any of these parameters saying that you would say both of these groups were somewhat equal in the parameters that would affect your stone ablation. When we look at the results, we find out that, again, the blinded review by the surgeons of the videos, we show a significant difference in the amount of retropulsion. And just so you are aware of the scale, scale 1 is where there is minimal or no retropulsion. Scale 5 is retropulsion that is interfering with the procedure that requires you to abort the procedure or change the setting, right? So the thulium laser gave you a 1.6 mean score versus the Homium laser was 2.8. Again, these are by the same surgeons. So these are experienced surgeons that are doing this. Same thing with the visibility, 1.8 versus 3.3. This is where the most significant difference was seen. And in bleeding, there was a non-statistical difference between both of 1.1 versus 1.9. Again, these are experienced surgeons, so they're more likely hitting the stone rather than hitting the surrounding tissue. When we look at the settings that really make a difference, I want you to focus on the ablation speed here. And this is where they say, you know, the thulium laser fiber is 4 times more effective and efficient than the Homium laser fiber. And we showed that this is almost the same 4-time difference. And the ablation speed in the thulium laser was 4.1 versus in the Homium laser was 1.19. Ablation efficiency was almost double, where the thulium laser was able to efficiently break, using the same number of joules, it was able to break more stones. And the speed is, it is able to break the stones faster, meaning it is able to deliver more energy at the same setting to break a larger volume of stones. And if we look at the operator duty cycle, this is where the difference is in the efficiency. And basically what is here is that the surgeon or the urologist was able to spend more time on the pedal activating the laser because of the less amount of retropulsion, the less amount of disturbance in their visibility, and their ability to maintain the stone within a distance or within a certain area within the kidney without needing to really pause and chase it. And this is the difference of about 50% versus 34%. If we look at the difference in the energy, these are actually megajoules versus kilojoules. The amount of joules that you get out, or the amount of energy that is delivered from the thulium laser fiber, and you'll even notice it if you have a SOLTIVE and you ask your laser person what is the total amount of joules used, you'll probably get them in the kilojoules rather than the megajoules. So a significant amount of energy is being delivered at the tip of the fiber itself. The laser on time, so the amount of time that is required to break, the mean laser on time to break these stones, and again, there was no difference in the stone volume or the density, was way lower in the thulium laser fiber, almost 200 seconds less. And the stone-free rates, we only had a percentage, about 60% of the patients did post-operative CT scans within 2 weeks, and we found that the stone-free rates were higher in these patients that completed the follow-up scans in the thulium laser fiber, almost double that to the Homium laser fiber. And these are just the differences that you can see on a bar chart, where you can see the stone-free rates. Thulium is in orange versus the Homium in blue in the ablation efficiency, in the ablation speed. So the ablation speed was the biggest differentiator here. The operator duty cycle, the laser on time was less in the thulium fiber. The energy required for stone ablation was way higher. And this is the difference between the bleeding, the visibility, the retropulsion, and both patients were equal groups. We also wanted to look at the differences based on how the correlation of the operator duty cycle, which is the efficiency of the stone, compared to several parameters, because we wanted to see if the operator duty cycle was really a metric that we could use to really measure laser efficiency. So basically, if you have a more dense stone, if you have a larger stone, or if you have a more complex stone, you're more likely to have a less efficient laser ablation. And so all these were negatively correlated with the operator duty cycle significantly. Same thing with the retropulsion. If you have more retropulsion, if you have less visibility and more bleeding, you're probably also going to get less efficiency. And we found that true in our data set. So the operator duty cycle was inversely proportional with all these parameters, showing that the thulium laser fiber having a better operator duty cycle showed more efficiency, probably as a result of these parameters. This is a very interesting thing that we did. We wanted to look at really the cost effectiveness. And the reason why we did this was because we wanted to acquire the thulium laser fiber, a second thulium laser fiber, or a second SOLTIVE in our hospital at a surgery center. And therefore, we needed to give the hospital itself a way to say that we are actually saving costs. And this is a very arbitrary formula. And this was actually published in both an abstract at the American Urology Association and in a publication. And basically, this is what the formula comes down to. It says that the mean difference in laser on time, right, because that is your time that you're using to break up the stone, multiplied by $100 per minute, which is the average that is billed for a uteroscopy in the US. This is subtracted from the difference between the laser fiber, and this is a non-ball tip, so a ball tip 200 thulium laser fiber versus the non-ball tip regular Homium YAG laser, plus the price differential to upgrade to a SuperPulsed laser system, which is a SOLTIVE Premium. And the difference there, based on an academic center, was about 18,800, and we amortized that over 1,000 procedures because the laser is supposed to last that long, came to 18.8 per case. So since the thulium laser fiber was 2.6 minutes faster, and this is for all stones, of course, for stones that were less than 15 millimeters, the thulium laser was more effective because of the reduced retropulsion and the increased efficiency, while for stones that were larger than 15 millimeters, they're already less likely to move, even though you have reduced retropulsion, and that's where the Homium laser was able to creep up, and the difference was only 1.7. So for all the stones, an average overall projected cost saving was about $70 per case. And again, this is based on our own analytics and our own debate or analysis based on the 3 surgeons that were enrolled in here. This can change from one institution to another. But this was to allow our institution to say, if we use this laser, this is how much we are going to save when we incorporate all the difference. Because their main issue was, well, the thulium laser fibers are far more expensive. Yes, we put that differential in, but you're also saving in operative time. And they looked at that you can add maybe 1 or 2 cases if you have a long list of stone cases. So if you look at the graph to the right, this is the difference in the laser on time for all the stones. And this is for the stones that are smaller than 15 millimeters versus the stones that are larger than 15 millimeters. We use that cutoff because that's where we found the difference. And these are the difference in the laser fiber from the Homium to the thulium. There's about 178 difference in the price of the laser. And this is the cost per case, which is $18.1 if you're going to upgrade to another laser, the SOLTIVE laser, and give back the laser that you have. So it's $69, about $70 for all the stones. If you're actually more prone to do stones that are smaller, your savings are about $143, while if you have very large stones where you might be more likely prone to use a PCNL, you still save about $26 per case. So it's very interesting. This is a very simple formula to use. Again, I would advise you, if you're looking to upgrade to a SOLTIVE laser, the SOLTIVE Premium, again, there's another type of SOLTIVE, but the SOLTIVE Premium is what we're talking about, then we really want to be able to tell our administration that this is the cost saving that we have. All right, this might be a good time to look up any questions. Brian, are there any questions in the QA that we can answer before we go into the videos?
Yes, Dr. Ghazi, we have a couple of questions here that we can address. So I believe you mentioned, I believe this person asking the question heard you correctly, as I think I heard the same. You did not use an access sheath. you and your investigators during this during the study. Now, during its use, are you concerned at all regarding the heat SOLTIVE may generate endoscopically? And from what you're seeing in cases, how does it differ from the 100-watt Homium YAG you were previously using?
Excellent. This is a great question, and thank you very much for that. I know that the thulium laser fiber SOLTIVE, there's a great concern about the temperature. So number one, we didn't use access sheaths because we knew that was going to affect visibility and also be able to affect we didn't want the surgeons to feel at some point that they had to stop dusting and just basket the stone. So we limited the use of access sheaths because we wanted everything to be equal. The second part of that is, I know there's a big concern about temperature, but really, I've always said this, and I've heard, and Ben Chu has said this in a significant number of his presentations. Thulium and Homium laser is watt to watt, right? The same settings or the same settings, a threshold for settings that you would use to limit damage of heat, you would still use in the thulium laser. So 50 watts is the maximum that you would use in the kidney, and 15 watts is the maximum that you would use in the ureter. Now, because the thulium laser fiber has such a great range, you're more likely to be prone to go over that. But you can see in all my videos, I didn't go above the settings that are the threshold that we are all know beyond would lead to kidney damage or damage of the ureter. You have to be very sensitive about using SOLTIVE, a thulium laser fiber, at the ureter. That's where you're more likely to cause damage. Second thing was we used pulse irrigation, and that's a way in which we can have a heat sink that allows the heat to dissipate. The third component is I think a lot of urologists are very concerned and almost freaking out about the fact that, wow, if you use 1200 hertz, you're more likely to damage the kidney. If you use 1200 hertz and 5 joules, you're definitely going to damage the kidney. But the idea is when you take your hertz up, you have to take your joules down. So you have to stay within that threshold. Another aspect of that is really there are studies that have been done in vitro that have shown there's really no difference between both Homium or thulium lasers that in the production of heat. It was by Dmitry, and this was done in using the Russian version of the thulium laser fiber. They did an in vivo and in vitro setting and really didn't find any difference in the temperature that is generated. So I would use the same precautions that you use for your Homium laser, and you will stay safe and you won't have an issue. The last thing I want to point out is, as you saw in the operator duty cycle, you are more likely to put your foot on the pedal for a longer period of time. And I noticed that very early on, and that's why when I started doing the study, I wanted to measure operator duty cycle. I realized that I'm rarely taking my foot off the pedal. With the Homium, it was like, and then I stopped. With the thulium, you're going for a good 30, 60 seconds, and you're seeing the stone break up, and you're really not putting your foot off the pedal. That's where I would be careful, right? So it's known that you do not want to give a pulse for more than 60 seconds, especially if you're using high wattage settings. And in that case, and only in that case, I would say put in an access sheath. Right? You're still dusting, but I would put in an access sheath as a way of a heat sink. And that's why you don't have to use a very large sheath. You can use a smaller sheath. So you're not basketing fragments. You're just using the sheath as a heat sink. So I would suggest maybe using a 1012 or 1113 based on the scope that you use. Use an access sheath if you think you're going to be dusting for a long period of time and dusting using high settings. And based on that, you won't have an issue with your temperature.
Another timely question here, and then we can move on to your case videos, and then we can get to the rest of the questions at the end. So this comparison included a 100-watt Homium YAG in the 31 cases in that cohort. So, I guess it begs the question, certainly, if this comparison included a pulse-modulated Homium YAG technology, the results may be different both from a clinical outcome standpoint and the health economic standpoint. So could you kind of speculate as to how the results might change if you deployed a pulse-modulated 100, 120-watt Homium YAG laser as opposed to the 100-watt?
Excellent question. And as you said, this is a mere speculation, right? So I was amazed myself. So I was blinded to all the data, and I was amazed to myself that there was a 4, exactly like the literature said, there was almost a 4 in the speed. There was a 4x difference between both lasers. That is a huge difference when you look at the difference between a thulium and a Homium laser. When you look at the studies that were done, even as far as 2017 by Hilali et al., where they did an in vitro study and an in vivo study comparing the regular Moses to the pulse-modulated Moses, the increase in efficiency. So basically what they did is that they had they looked at the volume of stone that was ablated in vitro, and they found out that the volume of stone was almost by a factor of ranging from 1 to 2.2 based on which setting you use, and it's more likely in the dusting setting. The difference we found was by a factor of 4. So I would say we still would see a difference. It wouldn't just be this significant, but they would still be a difference. Now, if you look at the economy aspect of it, the fibers that come out of Moses are way more expensive, right? The pulse modulated laser fibers are more expensive. So that would even help with the thulium laser fiber being more effective, because not only would it, speculatively be more efficient, but the fibers actually would be cheaper. So you would actually have a larger difference, or that might counteract the difference in the laser on time.
Well, watching the time here, let's move forward with the videos, and then we can get to questions at the end.
Yeah, I wanted to just address a question I saw in the inbox. So Kurt Shelton had asked, out of the 100 cases we did at our site, how many of them were larger than 15 millimeters? Actually, a very small percentage. About only 10% of them were more than 15 millimeters, and it's not because we had a selection criteria. These are the cases that we encountered during that period. This study was done over basically a 3-month period, so whatever stones we encountered at that time is what we used. We are actually doing a study or collecting data on patients where we're using mini PCNL data. And that's where the stones are very large, and that's where I think, especially with a mini PCNL, being able to add the very small fiber, the 500 micron fiber, and ablate stones at a very high efficacy. And I use fragmentation settings just because the Venturi effect of the mini PCNL already allows me to evacuate these fragments very efficiently. I use 5 joules, and I'm able to really crack very hard stones very quickly. You just have to really be careful about the laser burn back, the fiber burn back, because you will probably, with a PCNL, you're closer to the stone than you would be in a uteroscopy. So let's move over to the clinical cases, and this is basically showing you the range of cases. So this is the first case that I encountered during, one of the very first cases that I encountered using the thulium laser. And I started with settings that I would consider are, very conservative. It was 0.1 and 300 hertz, so 0.1 joules and 300 hertz. And this is the setting where I start. This is a setting where I felt would be a good baseline. This was a small 7 millimeter stone in the upper pole. We used a P7 for those who have Olympus ureteroscopes. It's a bevel tip ureteroscope that's fiber optic, and it allows you to, and hence you'll see the pixelation in the view, and it allows you to actually go up the ureter almost without needing to have a guide wire or put an access sheath. So here we identify the stone, the laser fiber goes in, the stone is in the field of view. You can see it's already like a hard calcium oxalate stone, and we started with 0.2 and 300 hertz. And within a couple of seconds, and this is in real time, within a couple of seconds, the stone is already almost in pieces, right? The beauty is it's not moving. The fragments are flying around, and the fragments are separating from the stone, but the bulk of the stone itself is staying exactly where it is. Again, looking at the view that you would get from a fiber optic, at the end, you end up with almost these minute fragments. Now, these still need to be addressed. So this is where we change the settings into the pop dusting setting. And if you want to pop dust, if you are a fan of pop dusting, this laser is incredible. If you have a stone in a closed calyx or trapped in a calyx, preferably the upper pole, and you start with 0.8 or 55 or 0.6 and 6, that's Ben Chu's preferred settings. Again, less than 50 watts, both of them, but you have to have the pulse modulation at 1. You can't have it at 3. And you just stay there for a couple of minutes, and you will realize that although the stones are kind of flying around, they're not really being pushed that far, but they are bouncing off the parenchyma and then encountering the laser fiber. And when they touch that laser fiber, they get disintegrated. Not like the Homium, where you have to really stay on the stone and make sure the patient's not breathing, and then put the pedal on for a couple of seconds, then the stone will break. These stones touch the tip of the laser fiber, and they disintegrate. And again, within, I would say, 30 seconds, the fragments that were filling up your field are not there anymore, right? You search around. We here, because the patient was breathing quite a bit, and this is, again, we don't choose our anesthesiologist. They put an LMA in, and therefore, as a result, the patient was breathing pretty heavily. I touched the parenchyma quite a few times with the tip of the laser fiber, and we saw minimal bleeding that resulted from that. So this was an excellent example of just showing you, very straightforward stone. The next, now this is a larger stone, right? This is, let's move over to the stones that we see kind of in the majority of our practice, rather than a proximal ureteric stone that we pushed into the kidney. So this is a patient, very dilated kidney. It was obstructed. The stone was pushed from the pelvis into, this is one of two stones that we had. So again, we pass the fiber in, and we start with, our regular settings, 0.1 and 300, which is on the right foot. And you can already see that the stone is, basically being broken out. That outer shell is being broken out. Here, I really wanted to see and test a fragmentation setting to really be able to understand how this laser fragments rather than dusts. Because I am I was never a duster. I was always one of the person where, why do we need to spend so long dusting the stone? We just break up the stone into pieces and, precisely break it up into pieces that go through an access sheath. I used to put a 12-14 into the kidney, which is a very large access sheath. And then as a result, I basket all these stones, and I would consider the patient stone free. Again, you see the size of the fragments, which are pretty significant. And then when you change into those pop dusting settings, and this is ideal where it's kind of in a narrow calyx, there's not a significant amount of space for the stone to go around, and you start those 0.8 and 55, and you break up the stone, and the stone really starts to disintegrate into smaller pieces. You just hang around in that calyx for a couple of minutes, and when one of the residents was mid me, was like, we're not doing anything. I was like, just wait for a couple of minutes. I'll show you the end result of this. I was like, we're not actually hitting the stone. I was like, no, you're actually hitting the stone pretty significantly, because not only are you delivering energy to the stone to break it, but also it kind of causes a suction effect. So if you actually had an access sheath up into that calyx, into the mouth of that calyx, I realized also when you do the pop dusting and then you start to pull back, the stones start to, it's almost a Venturi effect where they suction into the access sheath and they fall out on their own. So you don't really physically have to basket anything. Again, you spend a couple of minutes there, and all of a sudden those large fragments that you used to see within that calyx, you will then be able to realize that they're broken down. You follow them around. Again, this is a wide neck calyx, so some of the stones can escape. But this is an excellent example where these are significant residuals if you leave these in. You put your bop dusting settings on, you change it into a lower pulse rate. I've moved away from changing alterating the pulse modulation to a high and low. The sweet spot of this laser is in the low pulse modulation. And if you stick with that and able to explore the settings that work best for you for dusting and for fragmentation, you will get the best out of this laser. And that's what a lot of people are struggling with, really identifying what setting works for them. Because we're so used to using settings that are very limited in the Homium laser, it's very difficult for us to explore beyond those settings. It's not the same setting. The settings that you use in the Homium are not going to work in this laser. You have to really move away from your settings and experiment with which settings. I would suggest if you start at 0.6 and 60, which is about 50 watts, that will give you a perfect sweet spot to start from. Then you can go up with your frequency and up with and down with your joules versus up with your joules and down with your frequency. Again, within a couple of minutes, you will realize that if you even look at the dust that's coming out, this is in the proximal ureter, you will realize that the dust that's coming out is pretty fine, right? It's not ultra fine, but this is considered fine dust. This is what the Homium laser does give you, and these are at somewhat fragmentation settings rather than at dusting settings. So there's a difference between both lasers in the settings, and this is something that I really want to hammer home in this presentation. When I started using this laser and started using the same exact settings that I'm using for the Homium, I really wasn't satisfied. Yes, there was a difference, but it wasn't the extreme difference that everybody was talking about. It wasn't the hype. You have to start to explore settings. Like I said, start 0.6 and 60 and then start to move around to that. Once you hit a sweet spot, you will realize that this laser is very effective. I personally believe that this laser, if you find the sweet spot for it, you will be able to actually do a specific setting for hard stones and a specific setting for soft stones. So I want to show you this, the incision component. So this is a patient that was post-BCNL, and they actually developed a closed or a stricture in the lower pole, and they had a stone recurrence. So what we did is we went in with a uteroscopy. We actually used, again, a P7, which is a very flexible scope that allows us to actually engage in the lower pole. Here's where we use the 150 laser fiber, and I wanted to go into the lower pole at the maximum angulation and then actually try to pass the 150 ball tip laser fiber, because it only comes in a ball tip, and it passed beautifully right into the laser fiber without needing to straighten out the fiber. So I'll show you this pretty quickly with the incision, and this is where this is a one-size-fits-all laser, right? You can change it into an ablation setting, an incision setting, and into a lithotripsy setting with both dusting and fragmentation. So 150 fiber is going to come in, and the 150 fiber is in the SOLTIVE, and this is the angulation that we were dealing with that scope, all right? So show you how we were getting really into that lower pole, and this is the kind of the stricture that developed. This is the 150 ball tip fiber that goes in. The settings for incision are 1 joule, 20 hertz, low pulse. And basically, again, very minimal bleeding, right? You did this, if you do this with a Homium, you will end up with needing to switch to a hemostatic setting and then really start to cauterize the edges or not be able to see the stone or encounter the stone. It's almost like a bloodless field, right? You start incising, the tissue separates very nicely, there's very minimal bleeding. Again, it's difficult because it's in the lower pole, but you're able to really deflect all the way down, and you can already see the stone starting to fly out, right? So it's a useful laser where when you have a condition where you need to do both incision of the tissue and also ablation of stones, it is a very useful technology. And this is the charring that you'll see, right? You'll see a lot of charring with this laser. It doesn't mean that you're actually hurting the tissue because the penetration depth of it is less than the Homium, but that is the effect that this laser gives, and that's the hemostatic effect that you have. I really want to show you the last video, so I'm going to skip over to the next video, which is the ultrafine. So this is one of my latest cases, and this is where I really got very comfortable with the thulium laser fiber and really started to explore what this laser can offer. All right. Unfortunately, I didn't have any uric acid or soft stones, because if you have a uric acid stone with a thulium laser fiber, you'll spend very minimal time breaking up that stone. So here is where, remember we talked about the vaporization and where you have that water that is trapped inside the stone. And when you start to use these so this is 1000 hertz, 0.025 joules, right? Again, because the efficiency of the laser fiber at the tip and the technology that is involved in the laser itself and how the energy is delivered through the fiber, 0.025 is actually producing energy that is sufficient to ablate a stone, right? So the stone is really starting to dissolve here. Here you can see there's almost no snowstorm effect, right? There is a brief push of pulse of dust, but then it goes away very quickly, right? Opposed to the Homium, where you end up with the snowstorm appearance and really can't see anything, right? So we're getting through the stone. Dusting takes patience, and those charring or that flare that you see with the laser, that's where you have a significant amount of those water bubbles that are trapped inside the stone, and when they vaporize, they lead to this kind of shock effect, and you can see the result is a cavity. Like when we go in and you see that shock, you get a bigger cavity inside where that interaction with the water happened, right? So I was looking at this and saying, why is this happening? And I read up and realized that we're actually able to kind of almost burst the stone from the inside. And although this is a very hard calcium oxalate stone, we're able to effectively dust it. Yes, it's taking longer, but you can see the quality of the dust. You can see the visibility that is offered by the dust. And this is where the modulation now goes up, right? Because you want to really effectively dust that stone. So your pulse modulation goes all the way to 3, and you start really breaking up the stone or dusting the stone effectively. The dust that results from this is ultra fine, right? There's almost kind of this sea of sand that you see around you, not fragments. You're not able to see fragments. You see a significant amount of sand. I want to show you the cavity that results from the ablation cavity. So I'm going to switch the settings again to 1200 hertz. But again, right, we talked about heat, right? People look at this and say, you're generating a significant amount of heat in the kidney. I'm on 25 watts, and I do have an access sheath in this patient, right? So basically, this is where I'm using the heat sink, and I'm using actually low wattage. So I'm not exposing to a patient to a significant amount of heat. So this is me switching over to the 1200 hertz. And you can see, look at the tip of the laser fiber. You'll see a cavitation bubble start to develop. And this is where I learned I have to actually move away. This needs to be like 2 millimeter stones, all right? And the fiber size, the fiber, this was a 200 micron fiber that we're utilizing. But you can actually use these settings with the 150. You would just need to bring it down to about 1,000. The 150 will not go to 1,200 hertz. The 200 will take you to 1,200 hertz at 0.025, right? Again, limitations in using the fiber itself, but 1,000 hertz is quite a significant amount. And this is the part I really wanted to show you, which is, see that cavitation bubble? And I pressed the pedal several times when I saw that happening, just to give you the idea of, that's the cavitation bubble that's actually resulting in the dust forming in the stone, all right? Then we switched over just to show you the difference between the ultra fine dusting and the pop dusting, right? So this is the pop dusting. The stone is being fragmented. So this is a great dusting laser, and you can see the fine dust that you can produce. It's also a very good fragmenting laser, right? You can then break the stone up into almost 6-7 pieces very quickly and use a basket to pull out the stone. So this is not only a dusting laser, this is basically also a very good fragmenting laser, right? So this is 0.8, 55. I like that setting. That's where I like to start because it gives you the maximum amount of wattage that's allowed in the kidney, and slightly below the 48 or the 50, that is the upper limit, because I like to put my foot on the pedal quite longer than I would actually be able to. So I'm decreasing that wattage in order that when I'm emitting that energy, I'm not emitting a significant amount of energy. And here is where, look at the tip of the laser fiber. It's not worn away that much. You do have to clean up this fiber every once in a while because, again, the amount of energy that you're producing is significant, right? You had a huge amount of stones in that calyx, and all of a sudden, after a couple of minutes, the stones start to decrease in size quite significantly. So this is an example of showing you how this laser is both a superior dusting laser, but it's also a very effective fragmenting laser. And you can see the difference in the retropulsion, right? In the first one, the retropulsion was minimal. Here, the retropulsion is significant because, again, you're changing in the settings quite significantly, and you're changing between the low pulse and the high pulse. Right, I don't want to keep taking away from any questions we have. So this might be a good time to see if there are any remaining questions in QA or any questions that the audience feel wasn't addressed in this event, so that we are able to, kind of tell them what we do, what our experience is. And I'm sure there are people out there that would have similar experiences and even maybe more, but we wanted to give you kind of an insight into how we utilize this laser.
Great job, Dr. Ghazi. We have a couple questions here. We don't want to go too much past 9 o'clock, but we can get a couple in. From a research perspective, where do you see your studies taking you next with comparing Homium YAG to SOLTIVE? What's the next kind of topic that you're eager to kind of pursue? The two things I want to do. I actually want to do the study where I'm comparing the pulse modulated Homium laser to the thulium laser fiber. But before that, I really want to find the perfect settings for this laser, right? Because that's the biggest. You have such a wide range of settings that we're not used to. It's like, we have all the candy in the world. We don't know what we like. You have to. I think I've started to move towards, there are settings that are specific for large stones that are hard, and there are settings that are specific for smaller stones that are hard or smaller stones that are soft. When you get into the sweet spot of this laser based on the stone density, and I think my research is going to develop looking at the stone density in the CAT scan and trying to figure out what range would fit this stone the best. And I think we can reach maximum ablation, because a lot of people that I've talked to that are using this laser, after a kind of 2 minutes into the case, they're changing the settings. They keep changing the settings to a degree that they're not really sure where this laser works, and then they become unsatisfied with it. You have to stick with a couple of settings, and I'm hoping to give a roadmap for people to say, based on this density and this size, these are the preferred settings that you should use. We got a question here related to your last video. Are we looking at stone fragments moving around more because you are trying to pop test, or are you trying to get a vortex effect in that instance?
Actually, both. So I didn't want to create a vortex in the beginning, but realized that 0.5 and 0.8 and 55 hertz actually creates a significant vortex that allows you then, if you have, again, an access sheath positioned correctly, that vortex the stone right into the, I could literally see fragments flying into the access sheath because it's positioned perfectly. So in the process of creating this pop dusting, you are actually able to create a vortex, but it also depends on the shape of the calyx. You realize this is a calyx that had a little bit of a wide mouth, but also was pretty deep, and that's why we were able to create that vortex effect.
You mentioned earlier in the presentation speculating on durability of the SOLTIVE of thulium fibers, it being a simpler design versus Homium YAG. Can you comment on your own personal experience with laser uptime and the reliability of the SOLTIVE laser versus the incumbent Homium YAGs that you had in the past at your facility? Are you indeed seeing less instances of errors and less instances of downtime?
Yeah, so unfortunately, it is an Olympus product, but the Empower is collecting dust at this point. I use two different types of lasers, of rooms. So when I do these cases, I have two rooms that I go from one room to another room. When a case ends, I start the case in the other room. So basically, I'm saving anesthesia turnaround time. And the SOLTIVE moves with me, right? So when I'm done and I'm putting the stent, take the laser to the next room. And with the Homium, that was an issue, right? Oh, we don't have the power outlet in the other room, or this is a huge beast to move, right? Even shutting down is a huge thing. It's like a washing machine turning down, right? This quietly, just with the cart, moves from one end to the other room, plug it into the wall, you're ready to go. Even if you put both of them together and you turn them on, the SOLTIVE takes significantly less time to reboot compared to the Homium laser, right? So I would say it is my preferred laser just because it's small, it's durable. For surgery centers, this is an incredible, like we have one in our surgery center, not the one I use, and that is very handy because then we're able to move it between rooms very easily.
We didn't cover this evening any stones in the lower tract, bladder stones. How does your strategy might change for a very dense, very big bladder stone? Do you stick to the settings you kind of showed this evening, or are you landing on something else?
No, I go up with the jewels quite significant, right? Because the bladder, you're using actually a scope, so you have a significant amount. We use a continuous flow scope, so we're able to get a significant amount of heat sink. The bladder is less sensitive to heat issues, similar with PCNL. When I do my mini perks, I actually have a scope going up into the kidney that allows excess drainage outside or fluid that's running in. So I'm always creating this circulation of fluid. In the mini PCNL and in the bladder, I can go up to 5 joules. And it effectively you don't really fragment with this laser if you don't want to. It's like almost you're chipping away small pieces. And if you have a wide bore, either cystoscope or access sheath or even perk sheath, you're able to drain out those mini fragments, which are around 4 to 6 millimeters. That would be the perfect setting, which is 5 joules. The hertz are about 10, and you're kind of chipping off like a chisel. You're chipping off the stone. So you're not wasting time dusting. You're breaking these stones into minute fragments that then easily with the scope just empty out.
You're a tremendous thought leader for certainly urolithotysis, but also for cancers of the urinary tract. Have you ever deployed SOLTIVE for treating, for trying to enucleate or resect or ablate tumors in the urinary tract, and what has your feedback been?
Yeah, I've actually used it for a significant number of my bladder tumors. So about a 2 centimeter papillary bladder tumor. I like to do in-block resections, and so I've been using now the SOLTIVE, and the incision is perfect, right? Because basically you induce no obturator reflex. You can visualize basically the fibers and the muscle, and you can start to kind of carve your way. It almost carves like butter. And using that 1 joule, 20 hertz, you doesn't char the tissue that much, but at the same time, it incises very beautifully, and there's no bleeding. Like, there's zero bleeding. It definitely takes longer, right? If you're using a loop as opposed to that, the loop takes half the time, right? That's another study that we're doing right now. But if you want to do an in-block resection, this laser is very efficient. There's no bleeding. There's no obturator reflex that you introduce. There's minimal really charring of the tissue. You can see the planes really well, but it does take a little bit of sophistication because really you don't have the instruments that allow you to kind of curve around the tumor. So you have to be you have to almost know how to do a whole lip to be able to do that. But I've done it with these small end block. It's taking a little more of time, but it's really a nice laser to use, because you don't need to have a hemostatic setting and an incision setting. That 1 joule, 20 hertz does both at the same time.
I think we know the topic of your next SOLTIVE webinar is bladder tumors and soft tissue.
Definitely.
So probably bad form by me to the last question of the evening, offering up something that could really fill up another hour. It's a tremendous topic and certainly something that's been underutilized and not talked about on a national stage. But Dr. Ghazi, we're already 10 minutes past, so great webinar. I personally have obviously seen a lot of cases and experienced a lot of these webinars, and I learn something new all the time. And thank you for being a thought leader for this emerging technology, and we are all very eager to see where your studies take you and how you evolve your practice around SOLTA and influence others around you.
Thank you very much, Brian. I want to really thank the audience for hanging out a couple of, beyond 9 o'clock. I'm sure at the East Coast time, a lot of people, getting very close to being at the end of a long day. But I love the interaction. I think this event was great. I think this event really brought light to what we can do with this type of technology. And again, I want to really end this by saying the iterations that we're using for Homium Laser is number 4, right? This is 4th generation. This is generation 1 for SOLTIVE. So imagine coming down the road, right?
No, absolutely. The sky's the limit in terms of this technology, and Olympus will continue to be at the forefront for that. So with that said, thank you everyone for attending. Dr. Ghazi, big thank you from the Olympus family, and very much appreciated. Have a good evening, everyone.
Thank you, everyone.